All right, we are at 12:01 and we have a rather packed agenda, so we can go ahead and get started. It is my pleasure to introduce everyone to Dr. Kara Mizokami-Stout, who is one of our endocrinology clinical champions and endocrinology leads on the Michigan Collaborative for Type 2 Diabetes project here. She'll be talking with you guys today about continuous glucose monitoring, tips and tricks, specifically in type 2 diabetes. This talk will be multifaceted, pertaining to both the evidence behind it, as well as implementation within practices. And if you do have questions, please do put those in the chat. I will be helping to moderate with Dr. Mizokami-Stout today. And we'll be passing those along to her. She'll try to answer them when they best fit in with the content, but some of them may get reserved for the end. The best way, let's say, is to put those questions in the chat. Without further ado, I will turn it over to you, Dr. Mizokami-Stout.
All right, can you hear me okay?
Absolutely.
Okay, good. Thanks, Jake, so much for that introduction. I'm excited to speak to you today about a topic that I'm very passionate about, continuous glucose monitors in type 2 diabetes. As Jake mentioned, I am Kara Mizokami-Stout. I'm an assistant professor in the Division of Metabolism, Endocrinology, and Diabetes at the University of Michigan, and I am also affiliated with the Ann Arbor VA. All right, some quick disclosures. I am funded through a grant through the National Institutes of Health. I have a K through the Career Development Award, studying the implementation of CGM devices in type 2 diabetes.
Recording in progress.
So in terms of our objectives today, we'll take a closer look at understanding the benefits of limitations of continuous glucose monitoring and glucose monitoring in general in type 2 diabetes. We'll then briefly discuss the different types of continuous glucose monitoring devices. We'll take a closer look at some of the CGM data output, and we'll briefly discuss CGM coverage here in Michigan. And then we'll end the morning by working through a few CGM case studies. So let's get started with the benefits and limitations. If you wouldn't mind muting yourself, thank you. I appreciate that. And then we'll also take, as Jake mentioned, questions at the end. So starting off, what are some of the benefits of glucose self-monitoring in type 2 diabetes? So there's no question that type 2 diabetes is very, very common. In the United States, over 37 million Americans have either diagnosed or undiagnosed diabetes. The vast majority of these diabetes patients have type 2 diabetes. And about 1/4 of people with type 2 diabetes require insulin. Despite this, less than half are monitoring their glucoses at least once daily. And in this insulin-requiring population, self-glucose monitoring has clear benefits, including improved glycemic control and reduced hypoglycemia. There's also increasing evidence for improvements in internal motivation and potentially as well for weight loss and physical activities that were found in smaller studies. So these benefits have not been seen as consistently in non-insulin requiring type 2 diabetes. And so what are some of the limitations of traditional glucose monitoring, both through the patient's lens as well as through our lens in the clinic? And unfortunately, glucose self-monitoring via fingerstick has many downsides. Here, as you can see here on the left, it's not only invasive and uncomfortable, but it also provides relatively limited information in comparison to the amount of burden that it places on our patients. Shifting to the A1C on the right, we use this in clinic and we rely on the hemoglobin A1C as a surrogate marker of glycemic control, though this similarly has many limitations. Why glucose fluctuations and hypoglycemia are not accounted for. And it's also, A1C is also inaccurate in conditions where there's alterations in red blood cell turnover. And then also genetic polymorphisms have been found, particularly in non-Hispanic Black patients with diabetes. And this can lead to different A1C values for the same mean glucose level. So you can see there's a lot of limitations for our traditional glucose monitoring. I think this slide shows some of the potential clinical consequences as well of just relying on the A1C. So the graphs on the right here depict two different patients, patient 1 up on the top and patient 2 on the bottom, both of whom have an A1C of 8%, but you can see that there is a lot of both high and low blood sugars in patient one's graph, and the average is actually still okay. But because there's a lot more hypoglycemia, there's a lot more risk for life-threatening hypoglycemia in subject 1 versus subject 2. But we do have to take a step back in time and appreciate the advances in glucose monitoring over the past century. And in fact, monitoring of glucose in blood has only been available since the 1960s, with substantial improvements in the accuracy and transportability of glucometers since that time. In 1999, the first CGM device was approved by the FDA for type 1 diabetes, and since then there's been also substantial improvements in this technology, including the wearability and the cost as well. And in the past 5 years, clinical trial and observational studies have demonstrated benefits in insulin users, and this includes the insulin-requiring type 2 diabetes population. So as I mentioned, there's clear benefits of CGM in insulin-requiring type 2 diabetes, including those on basal bolus insulin and those only on basal insulin. And one of the most prominent CGM RCTs that was done was the mobile study, and this was conducted in primary care practices throughout the United States, including one site here at the University of Michigan. The participants of this trial were type 2 diabetes patients on basal bolus insulin plus or minus non-insulin agents. And in this trial, 175 participants from diverse socioeconomic backgrounds were randomized to CGM versus usual care. And at 8 months, there was a modest but statistically significant reduction in A1C in the CGM arm. More importantly, however, the CGM arm demonstrated a substantial increase in the time and range that went from 40 to 59%. And we'll discuss more about the significance of the time and range in later slides. I think the most telling thing about the mobile trial was the follow-up study that they did, where the initial CGM users were then followed continuing on CGM, or CGM use was discontinued. And you can see here in the graphs that the initial glycemic benefits in terms of both the time and range, as well as the hemoglobin A1C that were seen in the CGM arm in the mobile study, were then lost after CGM was discontinued in the follow-up study. So, as I mentioned, the evidence for non-insulin users is not as robust, but it is accumulating. This was a recent randomized controlled trial done entitled the Immediate Trial, in which 116 patients with type 2 diabetes who were inadequately controlled in terms of glycemic control on at least one non-insulin diabetes medication. In this 2-arm trial, participants were randomized to either CGM plus self-management education versus self-management education alone. And the control arm also wore a blinded CGM in order to measure the primary outcome, which was the time and range at 16 weeks. And at 16 weeks, both groups had improved glycemic control from baseline, but the CGM arm plus education was superior with a 10% increase in time and range. There's also an adjusted 0.3% A1C reduction in the CGM plus education arm versus the education alone arm. Not shown here, but glucose monitoring satisfaction was also higher in the CGM arm. So in the prior study, CGM coupled with diabetes self-management in non-insulin users led to glycemic benefits. We conducted a similar study here at the University of Michigan in one of our primary care clinics using CGM coupled to a low-carb diet approach. And in this 2-arm quality improvement study, all patients with type 2 diabetes and a hemoglobin A1C of greater than 7.5% who were medically eligible for tighter glycemic control were randomized to either usual care, or they were offered the chance to participate in an intervention consisting of CGM plus low-carb nutrition counseling. And the primary outcome was hemoglobin A1C at 12 months. And in this study, despite a relatively low, about 30% engagement in the intervention arm, the A1C was 1.1% lower in their intervention at 12 months. And so what I think these more recent studies are showing us is that to be the most effective, CGM needs to really be coupled to another intervention. So whether or not that's frequent medication adjustments versus self-management education versus dietary counseling really depends on a conversation with the patient and what their preferences and needs are. So here's a summary of the RCT and observational data on CGM devices for type 2 diabetes thus far. So RCT data demonstrates a modest improvement in glycemic control reduces hypoglycemia, and improves treatment satisfaction, particularly in insulin-requiring type 2 diabetes. As a result, diabetes guidelines, including the American Diabetes Association standards of care, support the use of CGM in insulin-requiring type 2 diabetes. There's likely some benefits as well in non-insulin requiring type 2 diabetes, but the data is more limited at this time. And because of this, the guidelines are not routinely recommending for non-insulin users. And these differences are also reflected as well in the coverage for CGM devices, which we'll talk about later. I didn't present this data, but observational studies largely echo the benefits seen in RCT studies and also have demonstrated a reduction in acute diabetes events, including DKA and severe hypoglycemia, as well as all-cause hospitalizations. So let's talk more then about continuous glucose monitoring devices, or CGM devices specifically. Before we delve into the different brands of CGM, let's discuss briefly how the accuracy is measured, and this is particularly in comparison to traditional glucometers. So the most common measure of accuracy is something called the mean absolute relative difference, abbreviated the MARD, and this compares a glucometer or CGM derived interstitial glucose values to true glucose measurements. And so MARD percentages of less than 10% are considered to have good enough analytical performance for medical decision-making, so i.e. medication or insulin dosing. The newest versions of the most common brands of CGM devices, including Dexcom and Libre, have MARDs anywhere between 7 to 9%. And I talk about a MARD as if there's one MARD for each device, but in reality, MARD shifts based on differing clinical scenarios. So for instance, CGM devices have different MARDs based on how old the device is, whether or not the patient has CKD or chronic kidney disease, and then also changes based on what the true glucose level is. So you can see here in the graph on the right, the MARD actually goes up, reflecting less accurate as the true glucose level goes down. And so this makes CGM devices overall less accurate in new glycemic ranges. So that's something to keep in mind. The other thing to keep in mind is we're using CGM devices a lot more on the inpatient setting, but again, these are not approved by the FDA yet for inpatient dosing based on the lack of data reflecting enough accuracy for medical decision-making. That being said, on the outpatient setting especially, perfect is the enemy of good, and CGM devices are still more accurate than half of the commercially available glucometers. And this includes some very common brands that you can see in use here. And so in terms of the accuracy between the current commercially available CGM devices, like Dexcom versus Libre, these differences are pretty trivial, and in my opinion, should not be a reason to choose one CGM brand over another. So let's delve into more specifics of the CGM devices themselves. So CGM falls into two main categories. The first, which is not the subject of this talk today, is professional CGM devices. And this is the device where the wearer is blinded to the glucose data, but can be available to the clinician after downloading retrospectively. The second category, which is the focus of today's talk, is personal CGM devices, which are obviously much more useful to the wearer as the glucose data and trends are available to them in real time to help with medication adjustments, alerts for hypoglycemia, and lifestyle behavior modifications. And so personal CGM devices are then further delineated into real-time devices where the data is constantly available, or intermittently scanned devices where the user has to take an additional step to scan to access that data. And in reality, the differences between intermittent scan and real-time are pretty trivial as well. As a user, the data is pretty easily accessible on both types of personal CGM devices, and they could consist of very similar equipment. So there's a sensor that's worn for up to 14 days. This measures interstitial glucose every 5 to 15 minutes without the need for a finger poke. That's seen in traditional capillary glucose testing. And this provides a really nice picture of a glucose, of the wearer's glucose trends over the past 24-hour period. And the features of each device, each personal use CGM device can vary, but many include alarms for hypoglycemia and hyperglycemia. There's data share capability for up to 20 family members or friends. There's an arrow system to show where the glucose is headed in the future, and a logbook that can overlay on top of the glucose data when downloaded to view food, exercise, and medication use, and how those have impacted the glucose. So these pictures demonstrate the currently available devices here in the United States, the Dexcom G6 and the recently approved Dexcom G7 devices, as well as the 3 available Freestyle Libre system, the 14-day, the Libre 2, and the Libre 3, which are the by far the most commonly used devices. It's rare that we see the Guardian Connect or Eversense systems, at least at the University of Michigan. So here's more information on the Dexcom systems. So due to time, I won't mention all of the different features, but will point out differences from the Libre systems. So in comparison to Libre, all Dexcom devices are 10-day wear, while Libre is 14-day wear. They're slightly more expensive in general than the Libre systems, and then depending on the device, they may be worn on either the abdomen, as with the Dexcom G6, or in the arm, as with the Dexcom G7. The main benefit is that right now, the Dexcom devices pair with insulin pumps to create a hybrid closed-loop insulin delivery system. And this is because they are all considered real-time devices that don't require the patient to scan or manually access the data. In terms of the Libre systems, as I mentioned, the Libre CGMs are worn for up to 14 days. They're all worn on the back of the arm and are generally less expensive than the Dexcom systems. All of the intermittent scan Libre devices, so i.e. the Libre 14-day and the Libre 2, require the patient to scan and view their glucose at least every 8 hours in order to capture and save any glucose data older than 8 hours, because that data then transfers over to the cloud. And although it is planned, none of the currently available Libre devices pair with insulin pumps. That will change likely in the next 1 to 2 years here in the United States. As I mentioned earlier, the features and accuracy of CGM devices are similar. I pointed out some of the differences within the devices, but I'd also like to point out some of the device-specific nuances that can affect accuracy. And so this is namely interfering medications, which may be another reason to choose one brand of CGM over another. So the main offenders at this point are hydroxyurea with Dexcom CGMs and vitamin C with the Libre 2. Tylenol historically was an interfering medication with some of the older versions of Dexcoms, but really now it's only really high doses of Tylenol that interfere. And so there's probably more side effects from the Tylenol itself. So one of the most helpful features of CGM devices are the optional alarms for hypo and hyperglycemia, which are available in nearly all of the CGM systems now, except for the oldest Libre 14-day system. So similar to alerts from other devices, though, these alarms can be burdensome, and alarm fatigue is a very well recognized phenomenon. And so personalizing alarm thresholds is one way to minimize this alarm fatigue. So familiarizing yourself with what alarms you can adjust can really help patients to tailor their alarms so that they minimize this alarm fatigue. Before starting CGM, it's important to remember that CGM is a tool to help patients monitor blood glucoses. And so setting expectations about what a CGM can and cannot do is important so that patients are aware of both the benefits and the limitations of these devices. As a tool to monitor blood sugars, CGM can measure blood glucose levels or interstitial glucose levels. They can alarm for high and low blood sugars, and they can demonstrate trends over time. But CGM devices cannot give insulin. That's an insulin pump. And that's a very common misconception upon referrals to my clinic. And the CGM devices just can't do that right now. And then, patients need to be able to respond to high and low blood sugars. A CGM device does not tell a patient what to do with that number in front of them. So we need to equip patients on how to respond to these readings because they're going to get a lot of data. So let's then talk more closely about the CGM data. So how can these devices help? So from the patient perspective, CGM data shows real or near real-time glucose values, as well as short-term trends over the past 8 hours, specifically from that day on the reader device or on their phone. And there's also an arrow next to each glucose value. And so what does that represent? So to answer this question, it's important to remember that CGM devices measure interstitial glucose and are not a true capillary blood glucose measure, which is what a fingerstick glucose is checking with a glucometer. This interstitial glucose lags behind capillary glucose by about 15 to 20 minutes. But the arrow system can help the CGM wearer to determine where the blood sugar is headed, so where their interstitial glucose is in comparison to their capillary blood sugar. And the direction of the arrow delineates whether or not the blood sugar is rising, staying steady, or falling, and then depending on the number of arrows, what this rate of change actually is. From the clinician perspective, longer-term trends are important for how we counsel our patients on behaviors and medications. Looking at longer-term trends is important not only to better understand the physiology and where hypoglycemia, and as well as where hypo and hyperglycemia are occurring. And in my experience, reviewing these data on the CGM downloads is really crucial to building rapport and trust with patients as well. We're asking them to wear a device for days to weeks at a time that sticks into their skin to generate a lot of data on how to better care for their diabetes. And so they're really expecting us to look at this data and to help them make some tailored decisions. And I think that that's important that we do that. There are a few different ways to review patient downloads. The patients can always access their own data and send this to you as a PDF file or in the portal, or other methods of secure communication in each of your institutions. Otherwise, each brand of CGM also has their own unique downloading software. The Libre CGMs are downloaded via the LibreView software, and the Dexcom CGMs are downloaded via the Dexcom Clarity software. And so it's easiest for each clinic to have a practice, either LibreView or Dexcom Clarity account, that can then be linked to the patient's individual account, which allows easy transfer through the cloud and significantly streamlines the downloading process. So how do you pull a Dexcom Clarity report? So if patients are using their phone to view their glucoses, the process of obtaining data is very simple. So they can download the Dexcom Clarity app, which is, to keep in mind, it's a different app than that they actually use to view their glucoses. So they're using the Dexcom G6 or Dexcom G7 app, but the Dexcom Clarity app is specifically to be able to allow us as clinicians to access their data. So even if their Clarity account is not linked to yours and they're using your phone, they can generate something called a share code. This is like a 12-digit password. And you can use this password on the Dexcom Clarity website without logging into your personal account, and it pulls up their data. So in our EMR, we actually save that share code into each patient's chart, and have them save it for up to 12 months so that for a year, we know what their share code is and it's very easy to get their data. If, on the other hand, patients are using a separate reader device, either because their phone's not compatible with the Clarity app or because they don't have a smartphone, they must have a tablet or a computer-based Dexcom Clarity account that then links to the practice Dexcom Clarity account. And they must upload then their receiver at home, which then transfers to their Clarity account. And then within your office, you then transfer their data from their Clarity account into your account. For LibreView, if the patient uses a receiver device, the process is very similar. Their LibreView account must be connected to the practice account, and then they have to upload their receiver at home, or you have to upload it in the office. And this is a manual connection into the computer. If they use their phone with the Libre app to view their glucoses, the data syncs automatically from their phone to their LibreView account. And you can pull this readily using your LibreView account as it's transferred via the cloud. So this sounds complicated, but in both my VA and my university clinics, we've done a train the trainer approach with our MA so that they do the downloads as part of the rooming process, almost as if they would do, with vitals or checking your blood pressure or temperature, things like that. So once you have the download, you have a ton of glucose data. What do you do with it? So let's go through the most important elements of the CGM downloads, which are relatively similar between Dexcom and Libre. Let's start off with the statistic that's the most similar to our most familiar measure of glycemic control. So the glucose management indicator, or GMI, it's an estimate of the A1C based on CGM-derived mean glucose. And so the personalized goal is similar to your A1C goals for your patients. So namely, those healthier patients with longer predicted lifespans would have a goal A1C of less than 7%, and those older patients with more comorbidities have a goal of less than 8%. So compared to the A1C, the GMI is still more accurate in patients who have conditions that affect red blood cell turnover, but it's still an average. You still miss the glucose variability, the highs and the lows. Additionally, GMI data has been validated more in type 1 populations, and there's some evidence that it may be less accurate in type 2 diabetes. So let's move next to the time and range. So I alluded to the time and range earlier when discussing the CGM validation studies. So the time and range is replacing the A1C as the preferred measurement of glucose control because it does account for the glucose variability, so the highs and the lows. And additionally, as a CGM-derived metric, it's not dependent upon the lifespan of red blood cells. So essentially, the time in range is the percentage of CGM readings that fall in range between 70 and 180. And this is depicted here in the green bars in the graphs on the right. And then similarly, the time above range is the time when glucose is greater than 180 in the yellow and orange bars, which delineate time in high versus time in very high. And then the time below range is the time when glucose is less than 70, which is depicted in red. So time, you can see there's subtle differences in the two shades of red. That's time below range and time in very low range. The goals for time in range, time and targets correlate to the A1C goals. So a time in range of 70% is similar to an A1C of 7%, while a time in range of 50% is similar to an A1C of 8%. So therefore, any patient who has an A1C goal of less than 7%, we would want a time in range above 70%. Any patient with an A1C goal of less than 8%, we want a time in range of greater than 50%. And this is also true as well for the time below range. In our healthier patients, we are okay with a time below range a little bit higher at less than 4%. But for our older and sicker patients who are more vulnerable to hypoglycemia, we want to minimize hypoglycemia. So we're really aiming to minimize that less than 1%. So each CGM download has several pages, and depending on how many days of data, these reports can get very long very quickly. It can be overwhelming to review this much data on every single page. But to simplify, the most important CGM metrics are viewable on something called the ambulatory glucose profile, or the AGP portion of the download. And this is essentially a summary page with the average blood sugar, the average interstitial glucose, the time and ranges, the GMI, and then how often the CGM is actually being worn. There's also something called a trend line as well on the ambulatory glucose profile. And this looks at a 24-hour period between midnight and midnight to see where the glucose are actually following. And so the median glucose is depicted in the darker line. And then the shading around is equivalent to the 25th, 75th, and 95th percentiles of glucose value to give you an idea of the variability around the median at any 1 hour within the 24-hour period. So just viewing the trend line can tell you a lot about how to approach this treatment for this individual patient in front of you. So for instance, in this example, this patient is having a lot of lows between 2 a.m. and 9 a.m., corresponding to fasting hypoglycemia. They also have higher blood sugars later in the day, corresponding to postprandial hyperglycemia. So they most likely need a reduction in basal insulin and a strategy to target high blood sugars after a carb load. So for the overachievers, again, there's lots of different CGM pages and downloads to look at. There's a really helpful graph on how many episodes of hypoglycemia they're having. But the daily logs are a really nice insight into daily patient behaviors. And so this is particularly true if patients are willing to log their habits into the CGM phone app. So for instance, this patient has logged their carbohydrate intake and insulin dosing for all of their meals. And so this helps to make very tailored behavioral and medication recommendations. So reviewing CGM downloads may seem daunting and time-consuming. There is some credit for this in terms of billing. Interpreting 72 hours worth of CGM data is a billable procedure using the billing code 95251, and this is equivalent to 0.7 RVUs. It can be billed every 30 days by a physician or a physician extender, and it's usually covered by the patient's insurance. And at our institution, we have a CGM interpretation template available as a smart phrase that our MAs prep again as part of the rooming process when they download the CGM. We also have a CGM interpretation order set that adds the 95251 billing code automatically to our billing. So let's talk more then about CGM coverage here in Michigan. So obviously, whether or not CGM devices are covered by insurance is highly variable, and it's really a moving target at this point. In general, most plans are covering CGM for type 1 diabetes and for type 2 diabetes patients on insulin. And generally, coverage criteria includes the documentation of the diagnosis, insulin use, and the need for fingerstick glucose monitoring. CGM is a little different than a regular prescription in that it can be covered as either a durable medical equipment benefit or as a pharmacy benefit. In general, for commercial insurance plans, it's easier to send the prescription to the pharmacy first. Additionally, most Medicaid plans right now are covering CGMs as a pharmacy benefit with the exception of Meridian Medicaid, which they have to use Healthy Living DME. For Medicare, however, the use of DME is essentially required, and this does add a little bit to the documentation that is needed and sent to the DME company. So let's talk about how to prescribe then. So if sending to a pharmacy, send it in like a regular prescription. Keeping in mind, it's not only the sensors that are needed, but there may be additional equipment such as a transmitter and a reader device that will need separate prescriptions. And this is the reader device is whether or not they need that is based upon whether or not the LibreView or Clarity app is supported on their phone or whether or not they have a phone in the first place. If sending to a durable medical equipment company, it's very similar to a CPAP order. The patient must find out their insurance's preferred durable medical equipment company, and they make an account with that durable medical equipment company. The DME company then faxes over an order that has to be completed by your office, and typically with your last note, documenting those three elements of the diagnosis, the number of insulin injections, and the frequency of recommended fingerstick glucose checks. So the use of CGM coverage dot phrases have helped at our institution to ensure that all of the necessary elements are documented in the patient's note when a CGM is prescribed. And this helps your ancillary staff to ensure that they're sending out all the necessary equipment, and also so you're not having to go back to addend your note a lot. So as a content expert for the Michigan Collaborative for Type 2 Diabetes, many of the MCT2D practices have also used the Parachute Health online platform to simplify CGM orders for DME companies. And they report high success rates with this company, though we do not use it at the University of Michigan, so I don't have any experience with this particular platform. So let's move on now in the last aspect of our talk to work through a few CGM case studies, and then we'll go on to questions. So we have case one here, is Miss S, 59-year-old woman with a 25-year history of type 2 diabetes, previously on basal insulin, but was able to stop insulin after going on a low carb diet. She is on max tolerated oral or non-insulin therapies, and this includes metformin, glimepiride, pioglitazone, Jardiance, and Trulicity. And her A1C values generally hover in the 7% range. However, she came into clinic reporting some family stressors recently with one of her children, and really has had a difficult time because of this, adhering to her low carb diet. So I pulled up her CGM, and you can see here on her CGM, her average glucose is 231. Her GMI has gone up to 8.8%, and she's in range only 12% of the time. So then I looked over at her trend line, which you can see on the right, and she is running high essentially all throughout the day. Now, this is a patient who really is wanting to avoid insulin, as you can see from the rest of her regimen. And we're hoping that she's going to be able to go back to resuming a low carb diet once kind of her stress in her life has dissipated a bit. So right now we did agree to do a temporary trial of basal insulin, starting with 15 units of Lantus at night. And then I also put in a referral to social work to see if there's any ways that our team can support her and her stress level to try and help her get back on track with her diet. So our next case, this is Miss H, 59-year-old woman with a 20-year history of type 2 diabetes and obesity. A1C is typically in the 6 to 7% range on metformin and Ozempic. She messaged into the portal reporting higher blood sugars on her CGMs and starting on a short course of prednisone prescribed for an upper respiratory infection. So again, because she uses her phone, I'm able to very easily get into her CGM. And so this is her data. You can see that her GMI has gone up to 8.7%. She's in target range 37% of the time, which is definitely different from her. That's lower than prior. And on her trend line, you can see this very clear pattern of steroid-induced hyperglycemia. And so she's on a 5-day course of prednisone. So this is only just going to be a temporary thing. She's also never been on insulin before. So we talked about some options. And I actually went ahead and prescribed her, in addition to her metformin and her Ozempic, a very small dose of glipizide, which is a sulfonylurea, to cover the steroid-induced hyperglycemia. Now, had she been on a longer course of prednisone, or had been familiar with insulin and how to inject insulin, I would have gone for NPH to cover steroid-induced hyperglycemia, which is a little bit more classic. So next case, Mr. J, 72-year-old man with an 18-year history of type 2 diabetes, stage 3 chronic kidney disease, and coronary artery disease, status post CABG, and he's on metformin, Ozempic, and Lantus. He's tolerating all of these medications really quite well. He's just coming in for a routine visit, denying any recent hypoglycemia. Pulled up his CGM, and you can see for him, his GMI is 8.1%, which is really not that far off of his goal of less than 8% with his comorbidities and his age. But his time in range is only 36%, which doesn't really align with that time with that GMI. So we look at his time below range, and it's pretty high at 8%. Remember, this is someone who's a little more vulnerable to hypoglycemia. So his time below range goal is closer to less than 1%. So looking at his trend line to see where the lows and the highs are, you can see he's got some fasting hypoglycemia and some postprandial hyperglycemia. So for him, what we want to do is we want to reduce things that are going to bring his fasting blood sugars down, and we want to add things that are going to target those postprandial highs, or highs with the carb load. And so what we did with him is continued him on the metformin, of course, and then because he's having so many lows overnight, I actually reduced his glargine by about 20%. And then to focus on those postprandial highs, he's doing really well on the 0.5 milligrams of Ozempic, so we agreed to go ahead and titrate that up. And then he's got CKD and CAD. He really is a good Jardiance candidate. So we talked to him about that, and we ended up adding a half dose of Jardiance as well. And then I'll see him back within a month's time period to see, do we need to make additional changes. So our case 4, Mr. Z, 64-year-old man with a 25-year history of type 2 diabetes, complicated by microalbuminuria and pancreatitis, coming in for follow-up. He's co-managed in primary care, where he was advised to eat a lot of cheese to prevent overnight lows. And he came into endocrine clinic saying that he's having to eat a lot of cheese. And he's actually wondering if there's alternatives because he likes cheese, but he's like getting tired of it. And so he is currently on metformin, Jardiance, Lantus, and Novolog. So his dose of Lantus is 30 units nightly and Novolog 10 units with meals. So pulled up his CGM. And again, you can see his GMI is 7%, which is pretty good for him. That's near his goal. His target range, time in target range is 68%, which is pretty good. His time below range is a little bit high at 5%. So on his trend line, you can see some episodes of fasting hypoglycemia and then some specific to post-lunch hyperglycemia. And so for him, we've got a couple of different options. Again, we want to come down just slightly on that Lantus to try and reduce that time below range to as close to less than 4% as possible. We want to also do something specifically to target the post-lunch hyperglycemia. And we've got some options here for him. We could always go up on the Novolog with lunch. We talked about what he's eating for lunch and found some lower carb alternatives. And so he actually elected to try and reduce the amount of carbs that he's eating with lunch before we go up on the insulin. But some nice ability to have options based on what that trend line is. So our next case, case 5, so Miss Y is a 56-year-old woman with a 12-year history of type 2 diabetes, complicated by proliferative diabetic retinopathy, stage 3 CKD, obesity, and depression. She's on U500, 50 units twice daily, and Ozempic 2 milligrams weekly. And she reports difficulty with CGM sensors adhering to her skin. So some background on this patient. She has severe depression, and she's been hospitalized in the past for this severe depression. And this, her mood really does impact her ability to do self-management for her diabetes. So we've tried with the U500 and the Ozempic to really make her regimen as simplified as possible. So that's just some background to see like how can we help her further. Sometimes it's not always just adding more medications. We pulled up her CGM, and you can see that there's essentially like no data. She's actually only has 5% worth of data. She's only wearing her CGM either 5% of the time, or she has a Libre 2, which is one of the intermittent scan CGMs. So maybe she's not scanning and capturing and saving any of that data to be viewed later. And so she is telling me that the sensors are just falling off her skin. And so what can we do about that? So rather than make adjustments, because I don't really have a lot of data to be able to do that, and she's on a concentrated insulin, which I don't really like to make adjustments blindly. I made some suggestions to try and improve sensor adhesion, and then saw her back in a couple of weeks with more CGM data. So some notes on challenges with skin adhesion and skin irritation. These are common. Nearly 50% of patients experience challenges with wearable diabetes devices, including skin adhesion and skin irritation challenges. So the first step is always frequent site rotation and use of adhesive removal wipes to get rid of any remaining adhesive residue on the skin, which can sometimes be a barrier for new devices sticking. Troubleshooting for adhesion challenges is a little bit easier because we have a lot of options. So the first thing to do is always do something to prep the skin better prior to sensor placement. So that includes removing the adhesive residue, but also maybe adding an extra layer of glue, either with liquid adhesive or adhesive wipes like Skin Tack. You place that extra layer down and then place the sensor on. There's also some things to try and mechanically hold on the sensor better. So these are things like patches, dressings, and tapes that you prescribed through the clinic, things like Tegaderm. And then there's device-specific protective sleeves that are available outside of the clinic, either on Amazon or Etsy. And one of these devices is shown here on the right. And then for skin irritation, this is a little bit more challenging. So you can always try topical antihistamine sprays like Benadryl, or a nasal steroid solution like Flonase. Place it on the skin before you place on the sensor to see if we can kind of help quell some of the inflammation. But oftentimes it requires the last-ditch effort of switching to a different type of CGM device. Each CGM has their own kind of proprietary glue. And if you have an allergy to, Dexcoms, then maybe we're hoping we won't have an allergy to Libre. And so this is often our next step, and it's usually helps quite a bit. And so our next case, Miss C, 72-year-old woman with a 20-year history of type 2 diabetes with an A1C of 8.9%, and obesity with a BMI of 46 on 30 units of glargine, 10 units of Novolog, with every meal, semaglutide 2 milligrams weekly, and metformin. So she just had bariatric surgery and has stopped her Ozempic 2 weeks prior to surgery when she was on the liquid diet, and now wants to know what to do further. So we pull up her CGM. And actually, it looks pretty good. The yellow delineates some postprandial hyperglycemia, but mostly you can see she's actually having a lot of fasting hypoglycemia at this current time. But again, she just had bariatric surgery, so she's going to continue to lose weight. So she's probably going to have less insulin requirements for her postprandial hyperglycemia. So this is that low glucose event page that I talked to you about in the CGM. It can tell you that she's actually having lows overnight and later on during the day as well. So we want to do something with her regimen that's going to target both. And so for her, we're continuing off the Ozempic. We actually stopped mealtime insulin and cut the Lantus down to 26 units. And then again, as she loses weight, she's going to need further adjustments. So we're going to be in contact frequently through the portal to see if we can help to tailor her regimen even further in the coming weeks. Case 7, Ms. P, 60-year-old woman with a 15-year history of type 2 diabetes with an A1C of 7.8 and obesity with a BMI of 35 on metformin and semaglutide. She lost an initial 6 pounds with the addition of semaglutide 2 years ago. So this equates to about 3% of her body weight. Pulled up her CGM, and it actually looks pretty good. She's got a little bit of postprandial hyperglycemia after lunch, but her GMI is 6.9, her time in range is 82%. So from a glycemic perspective, things look pretty good, but she hasn't lost the weight that she was hoping to lose. So we talked about options for weight loss, always talking about other medications that may be more effective than Ozempic. We talked about other more strict dietary approaches, including structured programs that focus on low-carb approaches versus low-calorie intake, versus a bariatric surgery approach. And she had actually read a lot about Mounjaro and was wanting to switch from a semaglutide over to tirzepatide or Mounjaro. So we went ahead and did that, and then we will see her back to see if we can make some more impact in terms of her weight. Case number 8, so this is our final case. Mr. H, 51-year-old man with a 13-year history of type 2 diabetes, A1C of 9.2% and obesity with a BMI of 31, on metformin, Jardiance, and Ozempic, and Lantus. Didn't bring a glucometer to download, but did bring in a handwritten logbook with his blood sugars over the past few days. He saw a commercial about the Libre 3 and feels like a CGM would really help him to make better dietary choices. He tried calling his insurance, though, to see if they were covered, and ended up having to hang up after waiting online or on hold for an hour. So he has HAP insurance and wants to know if he can get a CGM prescription today. So here is his log. I get a little bit nervous about logs like this that show numbers that end in either 5s or 0s. Is this data true or not? Because that's not really, like, the average is really not reflective of what the A1C is showing me. But the CGM would be able to help out as well to see, are these true blood sugars or not? Can we rely on his A1C? Those types of questions. So for him, his major hangup is he just doesn't know if insurance is going to cover a CGM. And so this is where we have some really nice tools from the Michigan Collaborative for Type 2 Diabetes with a nice CGM coverage guide. And so what we did is we pulled up the coverage guide, found that it is covered for him as a pharmacy benefit. So we went ahead and sent in those prescriptions and also directed him to some resources through MCT2D for training. And then he's going to need some frequent follow-up for changes over the next few weeks as well. So this is a closer look at some of the tools that we have through MCT2D to help with some of these types of questions. If you go to our homepage, mct2d.org, you can see up here on the top, there is a tab called Resources that takes you to the resource library, which has some wonderful tools for both CGM, for medications, and for low-carb diet. So we went into the CGM tab in the resource library, and this is where this medication and CGM coverage guide is located. So you can see this includes coverage guides for not only SGLT2 inhibitors, GLP-1 receptor and dual GLP-1, GIP agents, anti-obesity meds, but here at the bottom, continuous glucose monitors as well. So it gives you coverage for device brands preferred by each payer. And so this includes payers that are through commercial insurance, like CAP here on the bottom, like our patient has. Again, you can see that he is eligible. It tells you whether or not there's a pharmacy or a DME benefit, and then what the coverage criteria are. But it also includes insurances that are more public options, so like Medicare and Medicaid as well. So other tools that are available in the resource library, this is just a snapshot for people who are specifically interested in CGM devices. If you're wondering, is CGM right for my patient? There's a CGM use case guide, which can help you to determine whether or not a CGM would benefit your patient. There's also a coverage worksheet that patients can work through themselves to make sure that they have all the elements that are needed through their insurance to cover CGM devices and how to navigate essentially their own insurance plans. And then, of course, our training resources for CGM devices, both with Libre and Dexcom devices. So with that, here's my contact information. Happy to answer any questions. And it looks like we have a few here in the chat already.
No particular questions in the chat on the content, Kara.
Oh, okay.
Mostly just operational stuff I was able to address.
Oh, okay, okay.
If anybody else has any questions for Dr. Mizokami-Stout, feel free to unmute and ask directly right now if you'd like. Before folks log. Oh, go ahead.
Oh, sorry, Jake. Kara, I was just wondering super quick if you've had any patients who used to be on the G6 and have transferred over to the G7, but upon using it, they're not really loving the fact that it has to be on their arm because they've been so used to the abdominal administration. And so do you find if they have to have replacement sensors that you'll get into things that you saw with the G6, that the Dexcom would only replace it when it was worn on the abdomen because that's where it was studied? So in the case of a G7, if they switch it back to the abdomen, they would be told you're not wearing it in the proper spot. So
yeah.
Okay.
We will absolutely. I've had patients say that all the time, like Dexcom won't replace it because it was worn on the abdomen. Ironically, most of my patients, I see a lot of type 1 diabetes. I'll give you that caveat. So most of them have Dexcom G6s because they have devices. But most of them have worn it on the abdomen so long, and they have, their insulin infusion sites that they also have to wear on the abdomen. So they're excited to switch it over to the arm. But in patients who had Libres beforehand and are switching over to Dexcom G7s, they're looking for other areas, or they don't have enough subcutaneous fat, or for various different reasons for comfort. That's the same thing. If you tell Dexcom, they will not replace it.
So then that would be the only limitation by telling your patient go back to the abdomen is it, in the case they need to replace it. But from a, comfort from us looking at clarity reports, that should be fine.
Yeah, I mean, the thing is, it wasn't studied on any other place, right? So, oh, can you guys still hear me? Something what happened here.
Yep, you're good, Kara. I just shared the slides so folks can see the screen while you're answering questions as to how to get
okay.
CME.
Yeah, it's not studied, so we don't really know the accuracy. That being said, people do it all the time, right? People wear CGM devices everywhere. Especially with type 1 diabetes, you run out of real estate at some point. And so you kind of have to be creative. And so I don't necessarily discourage that other than telling them that we don't have data on whether or not it's accurate in these areas that they haven't been studied. And then also there's the limitation that if it fails early, you're going to get a hard time through Dexcom about it.
Thank you so much.
Mm-hmm.
A couple other questions in the chat, and I'll read them off in just a second here, but I just want to make sure we get to this. So the CME instructions are here on the screen. This will be recorded, and the slides will be made available to you. So for the continuing education credits, this is all of the background information on how to obtain them. And the only disclosure for today's meeting was that our program director, Lauren Oshman, has stocks in publicly traded companies or stock options and diversified funds that include Abbott and other device manufacturers.
Okay.
I'm going to bring this back up to the screen here and just leave this on the screen so folks can make sure to get it. And then, Kara, there's 2 questions in the chat here.
Okay. I see one question here that talks about 3 patients wearing the Freestyle Libre, 3 and all of them had significant hypoglycemia. None were on insulin or had hypoglycemia agents, and weren't feeling lows like they normally have. So this is actually one of the challenges with Libre devices, and one of the concerns with wearing Libre devices specifically in patients who don't have diabetes. You get a lot of false positive lows. Either because, again, the MARD is not accurate in euglycemic ranges, so they're less accurate in euglycemic ranges. You can also get something called compression lows, like if you're laying on your arm and then you're compressing the interstitial glucose flow to the CGM device, you can also get what we call a compression low. So if someone isn't having symptoms and they are having a low, it's likely either a false low from the device itself, and you can have them double check this. This is one case. This is when we will use a glucometer to double check that a capillary glucose compared to an interstitial glucose. Or, they're having a compression low if it's occurring in the middle of the night. But again, you get worried about hypoglycemia a lot when it's in conjunction with symptoms. And so it's not like all of these people have insulinomas. So that's one of the things we shouldn't worry patients about some of these things, because it's often just the limitation of the technology. Let's see, our next question. Do you know of any upcoming functionality for CGM readers apps to read aloud blood glucose levels? I have a couple of patients who are blind, and I hope they add this function. Yes, I do too. I actually have one patient who has a tandem. She's on a hybrid closed loop insulin pump with a Dexcom G6, and her blood sugars the iPhone will actually read aloud through the voiceover right now with her Dexcom. So if you have patients in that scenario, that is the only scenario that I'm aware of that it'll actually give you an audio glucose alert. Let's see here. Any other questions? Happy to take any more if anyone has any other questions.
I don't see any others in the chat right now, and it is exactly 1 o'clock. And so we can go ahead and wrap up. All right, Angela, I see your question in the chat about the CME. We'll check into that and get back to you. But if you do have any other questions, feel free to reach out to us directly, and I can pass those along to Dr. Mizokami-Stout. But otherwise, we'll go ahead and wrap up because it is exactly 1 o'clock, and we don't want to take up any more of your afternoon. Thank you, everybody, for attending, and have a great rest of your day.
Bye.